Hello friends, welcome back to my channel in my new video. This is a part 4 on the sedative analgesia NMB series. So here we are talking about the interventions now and a bit on delirium also. So it's a daily interruption of sedative infusions in critically ill patients undergoing mechanical ventilation, and that we all know that we have these spontaneous awakening trials as well as spontaneous breathing trials, and this was an RCT with about 128 odd patients who are ventilated in MICU, and the intervention group, the sedative infusions were interrupted until the patients were awake on a daily basis, and in the control group the infusions were interrupted only at the discretion of the clinicians, not as a protocol. So what they found that in patients who are receiving mechanical ventilation, daily interruption of drug infusions decreases the duration of mechanical ventilation and the length of ICU stay. This was NEGM 2000, and this was a ABC trial, or the Awakening Breathing Control trial, which was published in Lancet in 2008. So this was an RCT with involving about 4 centers and 336 mechanically ventilated patients, and they found that the daily spontaneous awakening trial followed by spontaneous breathing trial, which is an intervention group, or with sedation per usual care plus a daily SBT, that is a control group, so not as a protocol. And this was a ABC trial, and this is the protocol for the wake up and the breathe kind of protocol, where you could see that there is a initiation of mechanical ventilation, then awakening trial safety screen, then you perform the SAT, then the SBT scene which is seen, then you perform the SBT and then consider the extubation. So what was the ABC trial showed that the wake up and the breathe protocol, which results in better outcomes for mechanically ventilated patients in ICU than the current approaches, and should become the routine practices. And that's what probably we all are doing in the present day scenario. Now, talking a bit on delirium, and as we know, it's a acute reversible disorder of attention and cognition, and it is, as we actually, if you remember the Mars survey in 2013, and they have under recognized delirium, but which is so common in about 60 to 80% of the patients who undergo mechanical ventilation, and it is a predictive of the threefold higher reintubation rate, 10 additional days in the hospital, and higher ICU inpatient and 6-month mortality. So delirium per se, if you really see, is a marker of so many other things, and picking up the delirium is so very important, because its implication on the morbidity and mortality are so very significant. And as we know that the delirium is often invisible unless you look for it, as we know that there are the types of hypoactive, which is a quiet, and a mixed, which is about 65%. Only 1% is pure hyperactive. And so this difference of delirium, the recognition of delirium, should be well versed when we see the patient on a daily basis. And as we know that it will present as either a acute mental status change, or a fluctuating mental status, or a disorganized thinking, altered level of consciousness, hallucinations, delusions, illusions, inattention, and then of course they will lead to anarousability to coma. So these are very common things which we can actually come across when we are taking rounds. And I think after today's lecture, make it a point that you should not miss delirium, because it has so very important implications. And of course, the drugs of choice as haloperidol or risperidone and quetiapine, and definitely not giving benzodiazepines to this patient should be the key. Now, this is a CAM ICU flow sheet, or confusion assessment method for ICU, where you do some acts, and if they are done wrongly by the patient, you term this patient as whether the CAM ICU is positive. If the CAM ICU is if negative, that means that there is no delirium. And here the patients have done maybe less than two errors or maybe about two errors. If they are doing more than two errors and the RAS which is more than zero, then of course so if it is if it is plus 1 plus 2 plus 3, then you are going towards hyperactive delirium. If it is minus 1 minus 2 minus 3, you're going to hypoactive delirium. So if the CAM ICU is about say 2 or less than 2 errors, then there is probably no delirium. And CAM ICU of more than 2 errors, clearly we are looking at a delirium. So this is to be understood in a very simple or a straightforward fashion. And I think talking about the ABCDEF sedation bundle is so very important, and this is my concluding slide for the today's video. And it talks about A for awakening, B for breathing, which is a paired approach, C for the choice of sedation and analgesia, D for delirium monitoring either with the help of CAM ICU and the management thereupon, E for early mobilization, physiotherapy, occupational therapy, chest physiotherapy, and so on and so forth. And F stands for the family counseling. So you need to take into account and into confidence the family members. You need to talk to them at least once in your daily schedule. You have to have a specific time for the counseling sessions, and you need to actually inform them that this patient has a delirium or not based on whatever the objective and the subjective parameters which you have used. And as I said, I think I will probably again emphasize on the fact that the CAM ICU methodology and the RAS scoring system has to be displayed in your ICUs, either in your respective cubicles or in your ICU at one place. I think that is a necessity of time. And this particular ABCDEF bundle is taken from this current opinion of critical care in 2011, which was quite some time back, and critical care medicine in 2014, so about 10 or 11 years back. So this is it. I think I will stop here, and we will conclude this series in my part 5 of this particular series the next time. So for now, it is goodbye. Take care.